Welcome to the Heart Rate Variability Podcast. Each week we talk about heart rate variability and how it can be used to improve your overall health and wellness. Please consider the information in this podcast for your informational use and not medical advice. Please see your medical provider to apply any of the strategies outlined in this episode. Heart Rate Variability Podcast is a production of Optimal LLC and Optimal HRV. Check us out at optimalhrv.com. Please enjoy the show. Welcome, friends, to the Heart Rate Variability Podcast. I am Matt, and I'm back here with our good friend, Anna. Anna, I think this is episode 4 or 5, 3? Yeah, 3, 4. No, I think this is 4. You're right. This is number 4. So welcome back to the show. I can now officially call you Doctor. So congratulations. I know that's obviously it's a process. When I looked at it as a master's level student, I said, no, thank you. So I have a little bit of additional respect for the process that you went through to call yourself that. And definitely, I just wanted to start out with a huge congratulations to you for that accomplishment.
Thank you. Yes, it's a long time coming. I remember being on the first episode with you, and I said I think I must have been in my 3rd or 4th year.
Yeah.
So it's cool to see that it actually ends up happening. We do graduate.
Yeah. And I remember talking to the Optimal team right afterwards. I'm like, we can't let this Anna person escape our orbit. We got to pull her in and keep her in, because I just remember both at the AAPP conference and then interviewing for podcasts. It's like, she's going to teach me a lot moving forward. And I want to, with this episode, talk about some of that teaching that you've given me specifically, both in my wheelhouse and what I focus on. And I just think a really great way to look at research with your dissertation. So I'm excited to explore that with you a little bit, because looking through it and chatting back and forth with you about it, I was just fascinated by it. So I would love for you to just give a little background on that and start sharing with our listeners just sort of what got you interested in the topic, and let's then dive into some of the work that you did.
Awesome. Yes. So it's interesting. When I came into grad school, I initially wanted to study the neurophysiology of substance use, different factors and characteristics among adolescents. And then it progressed into, my chair has asked me this, what got you interested in craving? And it's odd. I think I just got really fascinated by the idea of something that could be more real life factor, because we do a lot of like self-report measures, but something that is so hard to understand, hard to measure, hard to define. And you know how the field of psychology is and neuroscience, we don't agree on anything. So right. And it's not because of any animosity, it's just that these factors and these constructs are so complex.
Yeah.
So I was interested in substance craving, and then we were wondering how we wanted to go about that, because there had been plenty of primary studies, and then there were studies that were looking at it from different forms of brain imaging, but then there was also autonomic nervous system measurements as well, and to figure out which route I wanted to take with that. In my chair, Dr. Omar Al-Hassoun, he studied the neuropsych of different substance use disorders and meta-analyses. For those not familiar, meta-analysis is a quantitative method to gather results of multiple studies and synthesize into one large study to hopefully identify consensus or discrepancies across primary studies. And so I wanted to use his skill set, his strengths, as well as my curiosities in the areas that I wanted to learn, to have the kind of the most feasible, realistic, and for my own sake, interesting research. So we decided to look at doing a meta-analysis of cue reactivity across substance use disorders, and later narrowed that down to heroin versus alcohol. Um, and that was for various reasons. You know, alcohol and heroin have some similarities in terms of how they are both seen as depressants.
Mhm.
They're both highly addictive, and both have very serious withdrawal effects, and very high relapse rates. And also just seem to have across the craving research the most literature. And so the dissertation, I'll just read the name here, is long, is Functional Neuroanatomy of Craving and Opioid Use Disorder and Alcohol Use Disorder, voxel-based meta-analysis of functional magnetic resonance imaging of drug cure reactivity
That's why we call
study.
you doctor.
The long name. So essentially what we're looking at is, if we're trying to think about this from what these participants went through in these studies, is an individual, let's say, who has substance use disorder with opioids or heroin.
Mhm.
In this case, all the participants, it was heroin. They go into an fMRI machine and they're presented images of their substance of choice or paraphernalia. And then they're presented neutral images, which can vary from gray screens, mosaic, just like where the picture's all chopped up.
Yeah.
And then it can also include food or different emotional states. So the neutral kind of varies quite a bit across the research. And then they are presented both of those at random orders or different types of presentation. And they're looking to see what areas of the brain have increased activation using blood oxygen level dependent imaging. So we're looking at where increased blood flow is taking place. And so we were looking to see, would that be similar with individuals with alcohol use disorder versus those with opioid use disorder. And we found in our research that there was a lot of overlap. They were definitely more similar than different. However, opioid had some areas that were more distinct that alcohol didn't.
Interesting.
Yeah, and so it was pretty similar to regions that were proposed in like more theoretical papers, systematic reviews. And it was in areas that are known for being associated with self-reported craving with different measurements. It was also associated with increased activation areas that are associated with habit, also with areas that would be called, how do you want to say it? It would be inhibiting prepone responses. So the inferior frontal gyrus, which would be kind of like right down here, that's going to be an area that's going to be trying to say, let's not act on that impulse. And that would have increased activation. So there was 4 main clusters, and we also found that there was areas of the brain associated with object recognition, and then visual attention. So I mean, it makes sense, right? If it's a substance that they're familiar with using over time with classical conditioning, we know that the more they see that spoon or needle, that's going to increase that activation. It's more salient to the individual.
So let's go back, and because I would love to get from you a definition, and feel free to go wherever you want with this question, of craving itself. Is it like, on one hand, because I haven't done some work in addiction, I know when I say like I'm craving dessert or I'm craving chocolate, yeah, maybe, but it's a whole sort of different kind of realm of that sort of sensation. When I talk to people who are struggling with recovery or addiction, and we talk a lot about relapse triggers, and that obviously has a lot to do with craving. So I would like you can go physiologically with this, psychologically with this. What is our definition we're working with around the idea of craving itself?
So craving has multiple definitions, unfortunately, but they have really come to a consensus that it is not only a psychological reaction, there's a physiological reaction, a subjective reaction where the person just perceives that urge or that want to use. And it can be associated with stress, associated with those that have other current mental health conditions. That's something I'll bring up a little later, is that unfortunately, with research that's going to be on substance use disorders, they'll oftentimes isolate the participant sample to only substance use disorders and try to rule out any other mental health disorders.
Okay.
And you and I both know as clinicians, that's not what it looks like.
Right, exactly.
And from a trauma, trauma focused perspective, a lot of people are using substances to self-medicate or
Right.
self-soothe, or to survive, what have you,
Yeah.
right? And so substance use may be a way for them just to even have income to be able to manage the lifestyle that they have. And so it's that's where craving can be kind of messy, because it can be due to withdrawal, but it could also be to heightened stress. It can be due to, like in my research, it's on a cue. So let's say someone's struggling with alcohol use and they live in the United States where booze commercials are everywhere.
Yeah.
They're being essentially triggered all the time.
Yeah.
And that's why, like in our work with, relapse prevention, it's really hard with alcohol because it's so socially acceptable. But then, for a lot of individuals in different environments, that might be different, like with heroin, if they might still be seen it quite a bit.
Right.
And that doesn't even just mean the paraphernalia. It can be the houses they use and the individuals they use with, or different clinics that they visited that can still be associated, because that's how the brain, organizes information. So to the original
smells, sounds, all that stuff could be, a trigger for folks I've worked with in the past too, that it's almost impossible to name all of them unless you've worked with somebody very intensely for almost years, because they discover new ones themselves, I found, too, which makes recovery, like I said, when I look at recovery, and I would say, especially from something like heroin, though alcohol is so devastating, smoking's devastating as well. Like it almost, and I'll let you take over from here as the expert, but I almost see like it totally, the mind, the physiology, like almost wraps itself around the addiction, and everything's about using. And so when you stop using, there's so many pulls. I think somebody called it like ghost synapses that exist there. And if you've ever tried to give up something you love, you know that when you relapse, it's spectacular until the shame and everything else kicks in as well.
Absolutely. And that's kind of going back to your comment about it's, with substance use, it's so drastically maybe different than like if I'm craving a dessert, but actually a lot of research shows it's pretty similar for people that have, it's mostly with those that have like food addiction or like more severe presentation with food related disorders. But it is actually pretty similar, because even different, chemicals that are in like dairy, like cheese, it's very similar to the effects that heroin has on the brain. Sugar, very similar to how cocaine acts on the brain. And so that's where we see a lot of our individuals where, they might find like a replacement, right? So that craving response may be very similar, and they may resort, maybe we're trying at that point help them kind of from like a harm reduction standpoint, look more for, if they're using sugar, like that's okay for now. But there's different types of therapies they've tried, like cue exposure therapy, where they try to have the individual present with the let's say paraphernalia for heroin use, and they want them to pair with not getting the substance after, so that disrupts that paired conditioned response to that conditioned stimuli. But what they found was it was helpful to reduce the salience of it, but it didn't quite reduce the intensity of that craving experience like you're talking about, where like there's the increased heart rate, increased sweat glands, the increased actually the decreased temperature at our fingertips, all of that, right? So they found that pairing it with different forms of biofeedback, whether it's using skin conductance biofeedback or HRV biofeedback, that also allows them to cope with the craving response. Because I think sometimes in the field, we're trying to get rid of cravings, but the goal I have found clinically is that it's more of how can they manage cravings? Because it's wild. Some of my patients have felt as if it was their fault that they had cravings. And teaching them this physiology helps them understand that it's not their fault. They're not morally broken, or, I mean, obviously the chronic substance use changes the chemistry of the brain and the physiology of the body, where reward thresholds do change. And we know that from research. And that doesn't mean that when you have cravings, that's your fault. That's just because your body wants that substance and it's had it for years.
Right.
So I had a gentleman, a veteran, where he just came up to me and he said, "Ann, I'm so sorry. I you're gonna be so disappointed. I just have had cravings all morning." I was like, "Oh man, that's not your fault. That's because your brain
Yeah.
loves that heroin."
Yeah.
And I said, "That's not your fault." And I explained it to him. I brought my brain model and I explained to him what areas of the brain are being activated and how that has been seen across the research. And he goes, "Oh, so it's not my fault." And I go, "No, but how do we manage it?"
Right.
Right. And they have like Suboxone, naltrexone, naloxone, methadone,
Yeah.
where that the idea is to reduce the intensity of cravings, but they may still happen. So I encourage people to learn how to manage it.
Yeah. So I'd love to hear more, about, what you found, but also maybe just with your expertise, thoughts on, especially the HRV biofeedback. Because one of my teachers on addiction and trauma, Dr. Gabriel Mate, I thought, and he's not the first to say it, but I love what he does because it kind of simplifies a lot. Is like for addiction to be there, obviously, oftentimes behind the cravings is like you got to have a organism that can live, a human body, basically a substance or behavior that can be addictive, and then stress. And so that to me is like, oh, that all makes sense. And then all the trauma stuff on top of that, obviously being a type of stress and the life people lives. I think it's AA who does a good job of saying there's all those, like, if you're hungry, if you didn't get a good night's sleep, like 4 or 5 different things that you got to be really careful about. If you're angry, that can lead
Absolutely.
to that as well. So we obviously know, and our audience knows, biofeedback, mindfulness helps the stress response, but love for you to dive. What do you think's kind of going on there? What you find around the biofeedback pieces?
So I'm glad you brought that up because Dr. Gevertz and his student, Dr. Andrew Nix, they had or it was Andrew Nix's dissertation on HRV biofeedback substance cravings in an outpatient setting in San Diego. And I was lucky enough to put together a poster using their data collection and their synthesis and present it at AAPB at the first conference. And I think they did a really good job of really talking about how we can, like, what HRV biofeedback is doing for these people, right? Because, the goal a lot of times in HRV biofeedback might be to increase HRV.
Mm-hmm.
And seasonal allergies as usual. Anyway, so they will be, like an individual, as we've kind of talked about, they're not as well versed in HRV, like an increase in HRV might not for them be as meaningful as what it's paired with, right? So if they're having increased HRV, but it's also paired with, they feel like they're doing really well,
Yeah.
then that data becomes meaningful to them.
Yeah.
Right. So, some people are like, "Oh, higher HRV, what does that mean?" Right. So we have to find a way to make that data meaningful. So in this study, they had, I believe it was 22 participants in the HRV biofeedback group plus treatment as usual. Then they had 21 in the treatment as usual group, completely without any HRV biofeedback. And I believe it was a 5-week study. And what they were looking for is that they would get education on autonomic nervous system, how stress can influence cravings, and then they wanted to look at would their self-reports craving scores go down.
Yeah.
And because what was tricky is 5 weeks, if we're, it's not super long for maybe drastic changes in HRV, but maybe they can have some meaningful change in terms of their self-report cravings. And that doesn't mean necessarily that their cravings are bad or good. It's just more so how intense or how severe it is.
Yeah.
And so they were trained on how to do the breathing. They gathered their initial HRV, and they were more so asking them to self-report their training, just kind of saying, did I do it or not?
Yeah.
Which we'll get to that, where I think a lot of our research is going to change with having our more user-oriented mobile apps, having our home readers, because again, with this one, these people are going through a lot. They're in intensive outpatient. It's not it's not their fault if they're not doing every day, but you know,
Yeah.
it'd be nice to know if they are.
Yeah. Yep.
So no judgment, just so that we know, like
Yes.
maybe there's something to do with adherence or not, right? However, when they did, the group that had the HRV biofeedback did have clinically significant, statistically significant as well, lower craving scores at 5 weeks than the treatment as usual group. Did that mean that they relapse or return to use? That is unknown, unfortunately, but that might mean that that's a helpful thing to have in a treatment program, so that they can have the way that Dr. Nix incorporated in his poster. I just love, I wrote it down here, is the HRV biofeedback not only helps to possibly increase HRV, but it helps the individual to increase sense of self-efficacy to manage cravings. A lot of times they just feel like they are, like you said, I'm addicted, like the drug kind of runs me or the alcohol runs me. Help them just in general self-regulate their autonomic nervous system. Help them improve their interoceptive awareness. We know interoceptive awareness is a really strong variable for helping individuals have increased insight to managing challenging obstacles or managing things in their body. And then he also mentioned that improving autonomic nervous system and regulation, the HPA axis, may also help reduce the rate of relapse, because there is research to suggest that when individuals have higher craving scores, they're more likely to have a high risk of relapse or return to use. And if we have lower scores in cravings, which may be associated with improved regulation, that might ultimately reduce the chance of relapse. But I think, like you and I have talked about, from a trauma-informed approach, returning to use or relapse doesn't mean a failure, right? I think what we're going to need in the research moving forward is quality of life, their perceived future, their orientation towards their current lifestyle, because we can have people do really well and still have slips or returning to use.
Yeah.
So I think by having this tool and having other ways to look for outcomes in a way that is looking at the whole picture for the individual is what's going to be helping us to move forward.
Awesome. I would love to get your insight on, because on one hand, I mean, I might even have a little trouble if somebody asks me the question I'm going to ask you, is the connection between stress specifically and cravings. Because I could understand. I mean, I get, like, hey, we have this thing. I know I've been to San Diego called happy hour. So go to work all day, get stressed out, go have a drink or two. Your drug dealer at the corner bar is going to sell you drugs for cheaper than normal, so you can feel better and be happy. But, so I'm kind of wondering, in your mind, because craving seems like a psychological phenomena that could be viewed as distinct from stress, where maybe I just am stressed out, so I want to use just to feel better, might not cross over to what I call craving, but I like you said, I couldn't give a good answer. So I wonder just kind of how you're thinking about, a biological pull to use, which again, what I know about addiction, really crafts the dopamine, endorphins, serotonin, all those receptors are ready to use. So you got all that, but then stress comes in there as another variable, and just kind of the idea and how you conceptualize that relationship between stress and cravings.
Yes. So I think the phrase that kept going through my head when you first started that question was, what is what is the stimulus that triggers the craving?
Great.
Right.
Yeah.
So I think it comes down to, like, for example, in my dissertation, they were looking at cue-induced craving. So it's if they see something that is associated with their substance use. And here's the thing, it might vary because maybe they had really pleasant experiences, because like when they've evaluated like social drinkers, it might not necessarily be a negative thing for them.
Right.
They just think a cold beer that has condensation on it sounds real good.
Yep.
But then there's also cue induced where they see that substance and it might remind them of withdrawal. And the thing about fMRI research with this study was that there's usually a 6-second delay from when they see it and then what the brain imaging is going to represent. So it's unclear how much of it is like automatic versus they had time to reconcile it. So let's say they see the picture and they go, oh, I don't like seeing that. Like that reminds me of bad times. That might be too long of a response. And that might have been different versus if there's a 6-second delay, maybe we're just seeing the automatic reaction that's been classically conditioned. So like how much of it is like in their conscious awareness versus autonomic. So there is that for when it comes to cue. I think from a standpoint that substance use is comorbid with so many mental health and physical health conditions that I was reading about it this morning, actually, that like chronic pain, if they have a pain flare up, they might have increased distress, which distress might be associated with using, so their craving goes up. So I see it more as like craving is like the conditioned response to a stimuli that's associated with their substance use. That's how I've been able to conceptualize it. I'm not saying that that's across the field, but when I explain it to patients, like let's say I have for example, I had a gentleman who was a pretty heavy drinker, and even when he would see like a glass bottle, he would notice like his heart rate would go up. And so for some people, craving for their own perception is very physiological, and then for some of them, it's a little bit more cerebral, where they think, that sounds like a way to get out of how I'm feeling. And some of them will say, I didn't even remember that space of time I was using before I knew what happened. So I think it depends on what the research was saying too, is it depends on the severity, because what we'll see too is some people will have increased activation in the brain that's associated with more like areas of the brain with like balance and coordination and what's it called, the muscle memory, where it's like, remembering to ride a bike, like it's just that automatic. So I think it depends on the severity. It depends on what their cues are going to be or what their triggers are going to be. And so like chronic pain, it might be seeing medication bottle, or it might be having a flare up in pain. So I think craving really is that conditioned response to that factor or that cue that elicits it for them. And so what I've seen for most people, it seems to be stressors in general, right? And the thing too with our society is we very much normalize that if you're stressed, get rid of it, unfortunately. And we're trying to help the I don't know, sounds kind of ambitious, but like the nation and the world understand that it's how you manage stress, because we all need stress. It's important. But a lot of times with people that have abused substances, any type of stress or any type of discomfort or even eustress, like positive stress, they use with it because that's just been their lifestyle. They saw it in their family, they saw it in those they grew up with, they see it on the media. So I think a lot of it comes down to what I do with patients is like you said, it might take multiple sessions or years to really figure out what brings it up for you. And the goal is not to get rid of those cues, because they're going to be there. It's to be just aware.
And so one of the things that I'm fascinated with, and I've come to some of my own conclusions, but I realize I might be wrong, because neuroscientists, a lot of them come to different conclusions, and I really respect their work too. It's sort of that idea of like the brain being in some ways hardwired, that once variables hit, in some ways the outcome, if you knew it got enough information, you could predict the outcome at 100% accuracy. Like if you've got somebody who sees somebody they use with, that's probably going to lead to use themselves or a relapse situation. And I've always been fascinated, especially with my work around like change and motivational interviewing, is what about us as human beings that might not always show up on a brain scan can sort of start to act in a catch yourself, I guess is the thing is that I'm looking for here, is like, okay, when I've been in this situation every time for the last 15 years, I end up using. This time, all of a sudden, and this is where I kind of go back to mindfulness, I'm able to kind of catch my craving, so to speak, before it leads to behavior. And I'm not sure if this came out in your research at all, but you can speculate. I'll give you full runway to do so. Like folks that, again, may have been using 10 years every day, we both know body, mind, whatever you want to call it, is programmed to use around that addiction. And all of a sudden they start to find ways to make different choices. Do you have ideas of where that volitional control, if it does actually exist, kind of where that comes from? And I'll just leave that very vague to see where you want to go with it, or just tell me to shut up.
So I'll say this is gonna not be based off my research. However, in terms of the hardwired part, there is a lot of research on fMRI Q reactivity. So like the paradigm that was in the studies that I used, that would look at pre and post some type of an intervention. And there would be changes in levels of activation and areas of the brain that were associated with craving, or I mean, a lot of it's like correlational, right? So they're looking at, if there's increased activation here, is at a higher risk for relapse. And there's a lot of, I think, so I mean, different things like medication, a lot of people do really well with different medications to reduce cravings like Suboxone, naloxone, speaking from a research standpoint. I think also it's something that they talked about too. Let's see, Volkow is a really prominent researcher in substance use and neurobiology, and she talks about how, what do we do with this information? Can it be changed?
Mm-hmm.
And so there's studies to show changes, but I don't think we'll ever have something definitive, at least in the near future. I would say that it comes to I think it's going to be very biopsychosocial. I think it's going to come down to the individual's perception of their self-efficacy. Do they have some type of alternative self-soothing method? Just like, just take away the thing that's helped you feel safe your whole life when you've been experiencing multiple adversive traumas and events. So I think a lot of it comes down to, we have to look at the individual, right? Their culture, their perspective, and it be a very much of a multi-pronged approach.
Yeah.
And I think what it comes down to too is the individual having that readiness to do it. Because I think, there has to be this desire to change too. From motivational interviewing, if they have no consideration whatsoever, there's only so much motivational interviewing you can do. And so to answer your question, I think a lot of it is being person focused, helping the person find reasons to achieve some form of sobriety if that is the outcome they're going for. And something that comes to my mind when I think of this too is so for example, they have done studies where they look at, let's say they present a substance and then something that would normally bring like a pleasure response for somebody. So like a beautiful tray of food, or a gorgeous landscape of a sunrise, right? And they actually had sometimes hypoactivation in areas that are associated with pleasure, reward. And over time, though, they would see that change. And then the group that didn't have the substance use disorder would actually have like increased activation in those areas, because the individuals that are using the substance are artificially increasing their reward threshold to a point that is kind of like not realistic given our like natural rewards that we have. But they did find though that over time, if you pair, like, let's say they talked about it, I included in my dissertation that if you have them like doing exercise and they have a positive experience with it, okay, then over time that becomes a more enjoyable experience. And you see in the recovery world a lot, all of them want their gym memberships. They're working out nonstop.
Yeah.
So I think it's finding alternative ways to get that natural reward, but it's giving the individual an understanding that, it might not be reaching that threshold that you've had in the past. Over time, the brain does adapt to not having that substance. It takes time. So it's a tricky question, but I think a lot of it comes to meeting the individual where they're at, having a supportive environment, a reason to achieve sobriety, and a way to manage any kind of eustress or distress, so that they feel not only that feel like they're going to use, but they feel like, even if I want to use, I don't have to. So
Right.
I think that comes to like having, again, I watched this documentary. I love it. It's called Stutz, and he talks about the life force, and he says
Yeah.
that, the physical body needs to be in check, right? So if they're, like you said, they're hungry, tired,
Yeah.
and just agitated, that's asking for a recipe for disaster. All of us want to do something that's not super healthy when we're in that state.
Yeah.
And then it's meaningful social connections, helping them build relationships with people. They can see that, hey, they wanted to use at one point and they stayed sober. So I think it's
Mhm.
having some form of inspiration, accountability. And then the top level was relationship with the self and helping them to find a reason and purpose, right? If they have such a long like legal history and they have so many medical conditions, they might feel like at a point like, why do I stop using? My life
Yeah.
is so
Why would I
hard.
feel why would I stop doing something that, and one of my things that really helped when I got into neurobiology is I would often hear I use now to feel normal. I heard that so often. What I didn't appreciate from a trauma perspective is when I do this, when I teach people this now, I always like use a life satisfaction scale. Is my normal is probably if 10 is you're waking up every day and you're just in love with every minute of nobody's kind of there, is if my normal's an 8, which I'm fortunate enough to kind of probably be in the 8s if you'd ask me that question, that's my normal. So I thought they were using to get to an 8, where a lot of folks, like you mentioned, have had so many life struggles that contribute and then are exacerbated per the use and addiction, is that they're kind of using to get back to a 3 on that life satisfaction scale, where maybe the first time they used, they shot up to a 9, which just increased motivation to use again because it's the best they ever felt. And I don't care if it's you, me, or anybody we pull off the street. If I take something that makes me feel twice as good as I've ever felt in my life, I might want to do it again, right? Especially
Absolutely.
if I'm escaping that pain. So that to me is like that addiction can be so evil in that way, is that, and my whole misperception initially was, oh, they feel like I do when I wake up in the morning when they use, that's their normal. But it's still this state for so many people that's, I think if you just put us in that state would feel pretty traumatic and devastating.
Right. And I think what you're talking about with that level of satisfaction too is some of them might be trying to get to a 3 because that's what they're used to, but some of them might think they're supposed to get to a 10.
Yes.
And
Yeah.
I had an
Great
individual
point.
who he would be in the groups and the therapist would go around asking all of them, what's your level of craving on a 0 to 10? And the veterans would all say things like 10 being the worst, right? So
Yeah.
they'd say like 0, 1, 0, 2, 1. And I asked, and the individual I was seeing for individual therapy, and I said, what did you tell me your number was? And he's like, well, if I say too high of a number, they're going to think I'm doing something wrong.
Yeah.
And then I'm going to feel like I'm doing something wrong. And I said, but you're lying to yourself, right? Like that's part of interoceptive awareness is being aware with your body. And then part of mindfulness is being non-judgmental of what that experience
Yeah.
is. And so sometimes when I would run the groups, I would go, I know some of y'all are gonna tell me 0s and 1s, but we're in a rehab facility. No
Yeah.
bullshit, y'all. Like,
Yeah.
come on, what are we actually on? They're like 7, 8, 9s,
Yeah.
10s. And I was like, and are you using right now because you have a 9 or a 10? They said no. And I go, exactly. So that physical it's a lot of that education of invalidating that just because you have this high of a craving does not mean you're gonna run out that door and get a beer. Right.
Exactly.
And that for them, they're like, oh yeah, like it is down the road, isn't it? I'm like, sure is. If you want to go get it, you can.
Yeah.
And that's the self-efficacy where they can say, I'm sitting here, I want to use so bad that my body's shaking. I'm so uncomfortable and I don't have to. That's where you start breaking that conditioned response, right?
Yeah.
That having that craving experience, which is very different for many people, does not equal using. It can predict it, but I think they have to understand that even like what I tell them is, you working a solid recovery program and having cravings does not mean you're doing something wrong necessarily. That's just an opportunity for you to look in your body and go, what am I needing? What is something I can do to maybe help myself? Maybe that's helping somebody else. Maybe that's eating something that's a little bit more clean, not so inflammatory, whatever.
Yeah.
And so it's I think a lot of it comes to mindfulness and being aware of it instead of saying, oh no, I have cravings, so I have to use.
Yeah, absolutely. And that kind of the idea of that window of tolerance from Siegel, Ogden, and their work, like that's where I think the HRV biofeedback, I've seen it in my life and my use of it, being fortunate and privileged enough not to deal with addictive struggles like that, but not perfect in any way, shape, or form as well, is like is really opening that tolerance, building resiliency is a I know a loaded word, but I'm increasing my capacity to handle maybe some cravings, maybe stress, and I've got room or capacity to catch myself before the
Absolutely.
automatic, because almost once people get on these, the trigger can often trigger a cascade of behaviors that lead to then relapse. And depending on your drug of choice, that can be easy or hard, but it almost even if you got to get in the car and go somewhere, it's still almost like you're on. People tell me this is like you said, I don't even remember what happened next, because there's almost this automatic process, this flooding of those emotions. And the heart rate variability biofeedback with that ventral vagal brake, could be giving, again, I'm really making jumps from what you're saying, admittedly, but gives a little bit more of that capacity to bring that mindful awareness to say, okay, a craving doesn't mean I have to use. I don't have to follow
Right.
through. This is a craving. I can name it. I can own it. And it doesn't have to control me. And even with that, sometimes I eat the thing I know I shouldn't eat. The tater tots are on the menu. I know I should have a salad, but the tots look so good. So, and my desire for tots is nothing like the folks you're talking about with heroin or alcohol. I love them, but not
Right.
going to compare those two in any way, shape, or form.
Right. But you can understand how, even though you recognize it, that sometimes it comes to like maybe you were lacking salt or you were wanting
Yeah.
some different fats, whatever. So it's just like that curiosity, that awareness, even after it happened, right? So a lot of times addiction and many mental health conditions are perpetuated by unaddressed shame and guilt. And
Yeah.
so if they can target the shame and guilt and look at more from like, our compassionate approach or self-compassion practices, to say like, although I may have returned to use, or although I've had cravings,
Yeah.
or maybe I'm not as active in my recovery program, that doesn't mean I'm doomed. It means like, what can we do to kind of recalibrate and readjust what we're doing here? People can just be, and all of us, and me included, we can just be so hard on ourselves.
Yeah.
And I think part of this too, and part of even just a lot of people experience trauma and PTSD and different trauma related conditions, is they might kind of almost invalidate themselves for what they're experiencing. And so my biggest part is educating them on the impact of chronic substance use on their body. And so that that's one area that hopefully they don't blame themselves as much for, and then educating their families. And I think that's when I was, before logging on to this, I was thinking about how so much of research is not as accessible to people.
Right.
And how this is such an honor and privilege to actually spread that information, because you know, I've had so many families where I talk to their spouse or their friend or whatever it may be, and I explain to them some of the physiology of what they're going through, and that if they have cravings, that does not mean you need to like panic. It's just to be there with them and talk
Right.
with them. And they're shocked by the fact that it's not just because they are avoiding conflict or because they're a jerk or whatever.
Right.
They're like, oh, like that's something that their body's conditioned to do every time they see a bottle or every
Yeah.
time they see a spoon or what have you. And so the education is so important. And then I'm working on this is making that education understandable,
Yeah.
because it's heavy. It's a lot of
It
information.
is.
I
Yeah.
always thought it was funny how we, you know, in rehab centers, we teach the patient so much about neurobiology, but they're just trying to detox still.
Yeah. Well, and then to me too, like my work in, you know, and I love, and it hasn't picked up as much after COVID that I like it to, but training people that are in those scenarios and are in the struggle of recovery, whatever that means, for them working on that. And it's like, to me, once they, if I can communicate the complexity, and I've really found that I had somebody in one of my very first talks say, you know, you won't find, these were his words. I don't use the word addict to describe anybody, but I'll quote him. You don't find dumb addicts. Like there's no dumb addicts because they die. You know, very crass way to say it. Like I said, words I would not use from any perspective I take, but you know, just getting into that in a way that's, do we have to get into the different lobes of the prefrontal cortex? Not necessarily, but like I just remember like my first time I talked to folks, it's like two pieces of feedback that have just resonated. I realize I'm not a bad person. Like, and you know, as like a therapist, if I do really good therapy and somebody thinks they're a horrible person who's weak and just, you know, this, that, or the other, you know, that might be 2 to 3 months worth of work, depending on trauma. That was like a 45-minute presentation and people understanding why they might need treatment and support, because that idea of being a weak, broken person has so much shame in it. But understanding that, yeah, these are biological reactions. Probably your addiction was a reaction to stress or trauma, or with the opiate addiction I deal with so much with my work around the country, a really broken, unethical medical system that has its own, you know, role to play in this. Just that realization that I'm not a bad person, just such a powerful insight for folks to have. Doesn't mean it's over for them, the work. It's still a lot of hard work. But boy, if we can remove that shame, to me, that's such a barrier to change, that I just see over and over. Addiction, homelessness, intimate partner violence, well, whatever, disordered eating, all those things. Just like it's such a barrier to getting to the life. Maybe they can see it, but such a barrier to that change process.
Absolutely. And I think that's where you have individuals who say, like, am I worth recovering? Or their
Yeah,
family members or the world, unfortunately, has said you're
yeah,
once, they'll say things like once an addict, always an addict.
yeah,
And you know, that yes, they may have that long-term or lifelong recovery, doesn't mean that they're going to always fail. And I say in
right.
quotes for those that are listening audio. And
Yes.
I say that it's that's what I think is, you know, a lot of people say like, well, what is all the neurobiology of addiction research? What is that going to do? How do we use that to help
Yeah.
people? And I think a lot of it is reducing or hopefully eliminating stigma and
Yeah.
understanding that it does have medical impacts and long-term physical impacts. And we see in the research too, the Q reactivity research, which if I haven't clarified, I apologize, is Q reactivity is the measurement for craving using fMRI, but they'll also use Q activity using like heart rate and other things. But
Yeah.
when I say Q activity, I'm referring to how they measure craving. And so I think it's fascinating that we can say that they're, you know, they look at, you know, if you have family history of it, you might have different Q reactivity and you might have never even excessively used a substance.
Yeah.
They've looked at those that have had trauma history in the interaction of substance use. And those studies, you know, that was hard for the meta-analysis, was I had to really try to control for internal validity so that the we're looking at the impact of the chronic substance use.
Right.
So I was, unfortunately eliminating things if there was like a diagnosis of PTSD and anxiety and depression. And so like that interaction is, it's the realistic clinical world. And it's also possibly very much exacerbating it because I was reading about it this morning too, just because healthy eustress, where I'm trying to just get some fun facts for the podcast, right? And so I was reading about how the comorbidity of different mental health and physical conditions with substance use. One could argue that, if the individual has, well, I guess what I was going to say was that there's not as much research on HRV biofeedback for substance use. There is some for neurofeedback. But there is a lot of HRV biofeedback research for anxiety disorders, PTSD, chronic pain, gastrointestinal, panic disorder. And so then I thought, okay, if there's sound research for those, then we could consider that there's a likelihood that if the individual has that disorder, they probably are also possibly misusing a substance. And it's true. And like the prevalences we have aren't great. Like the range is like 20 to like 80, but we do know, like, I think the highest ones they said are like with PTSD, depression, anxiety, chronic pain. I think they looked at it was a super large sample for chronic pain, but it was like over, I want to say like 40% had some type of substance use disorder if they had a chronic pain condition. So I think we can, use it not as a sole approach, but we can use it as an adjunctive service in our approaches. I think also just measuring HRV to have additional data to evaluate their progress in their recovery, because there's mixed research on the long-term impacts of certain substances on HRV. Like some people have lower HRV if they chronically use a substance, but some substances doesn't impact it as much. And so I think it's more so like what we tell individuals, find your own baseline, work from there.
Excellent. I just want to give you, because I could talk to you about this all day long. Is there any other, as we kind of wrap up here, any other insights you've had, any other, like I always like to ask people who've done, especially meta studies, because they're so time intensive, and boy, I can't even imagine how many journal articles you looked at during this process. Any generalizations too, even though I'm not going to ask to be bad, but just kind of in your own head, like epiphanies that might not be exactly related to this, but larger epiphanies or any other insights you'd like to share as we start to wrap up here?
I guess I would say is that there's a level for individuals that are not as familiar with peer-reviewed research to have healthy skepticism, because that's what you learn in meta-analysis is, and I say that not in a negative way, say that as a perspective to have. So just because, across the research in our data analysis that these areas showed increased activation, and let's say those areas are associated with higher risk of relapse, does not mean that is the destiny. And so I think a lot of this more so is to educate ourselves as clinicians so that we are also being aware of our own stigma that we have with substance use, because it's a hard field, because we see it's a really I think there's really low percentages of individuals that achieve 1 year sobriety. Not that that's the only outcome, but it's a really hard and really tragic area to help with, and very rewarding too, because you see people get their lives back. So I think with my dissertation, I gathered that to read things with curiosity, to read literature with looking for details, looking for the methodology, looking at the participants, right, and reminding ourselves too that we're working from like a clinical psychologist who's going to be primarily doing clinical work now, is to remember that you're working with the individual, and that just because we have some consensus from different meta-analyses, they can be helpful in our case conceptualization, they can be helpful in education with our patients. And at this time, they're not really used as like treatment indicators, but maybe in the future they will. They always put that in the future research, use these as
Yeah.
treatment indicators, but fMRI machines are expensive. So
Yes, they are.
but I think it's to use it for those reasons and to remember that you're working with an individual, and individuals, we are all complex.
Yeah.
And that's something I learned not only in my dissertation, but this year internship, was that, we're not working with just lab rats. And I say that ironically because I love animals, but I mean,
Yeah.
Humans also have culture, and they have, event history, and there's a lot of factors that don't fit in a box like we can do in some of our research. So to remember that although we have such incredible findings in our research world, to remember the individual is there needing help, and that we're there to help them. That's kind of my biggest takeaway, honestly.
Well, that was beautiful. So I will not ruin that. We'll put some information about Anna in the show notes. She is a valued member of the Optimal team. So it's just been great to work with you, my friend. Congratulations. As we were talking about, I think you've been through 4 or 5 like major, exciting, yet, big, moved across the country. We can call you doctor, change of jobs, all kind of relationship excitement, all kinds of stuff. So it's great to be on this journey with you. Thanks for all that you do, and thanks for sharing your work with our audience. I know it'll be greatly appreciated.
Of course, pleasure and an honor. Thank you.
Awesome. And as always, you can find more information at optimalhrv.com, and we will see you next week.